Chairpersons, ladies and gentlemen, it's a pleasure to share with you the data of the PRIDE study, a comparison of the efficacy of ranibizumab and panretinal laser photocoagulation. These are our financial disclosures. Proliferative diabetic retinopathy is a common microvascular complication of diabetes. Panretinal laser photocoagulation has been considered standard of care for the treatment of PDR since decades with known destructive side effects. First studies with anti-VEGF in PDR showed promising results. We performed a phase 2 randomized controlled multicenter study. The PRIDE study, we included 106 patients and they were randomized to either ranibizumab 0.5 milligrams, to panretinal laser photocoagulation or to a combination of both. And I want to share with you the results of the 12-month core study. The key inclusion criteria were patients aged at least 18 years with all stages of proliferative diabetic retinopathy, best corrected visual acuity of at least 20 ETDRS letters, and HbA1c 12% or less. Key exclusion criteria were clinically significant macular edema involving the center of the macula, large areas of neovascularization within the macula, proliferative vitreoretinopathy, vitreous hemorrhage impairing imaging or treatment, and prior treatment with PRP within 6 months, anti-VEGF within 3 months, and corticosteroids within 6 months. The primary objective is the change in total neovascularization area from baseline to month 12 using standardized assessment protocol, and it was performed in a central reading center, the measurement. The key secondary objectives are mean change in best corrected visual acuity, mean OCT change in central subfield thickness, and safety. The proportion of patients that completed the core phase in the 3 treatment groups was comparable, as you can see here. The main reasons for study discontinuation were adverse events and loss of follow-up. We had 1 death in each group of the ranibizumab and PRP and 2 in the combination group. The demographics and baseline characteristics were well balanced concerning all those parameters here, especially HbA1c, best corrected visual acuity, and central subfield thickness on OCT. The PRP patients received initially 1,928 burns, the combination group patients 1,670 burns, and the investigators were allowed to retreat the patients every 3 months according to a specified protocol. The median number of ranibizumab injections was 5 in the ranibizumab monotherapy group and 5 in the combination group, with a mandatory injection of 3 monthly injections at the beginning of the study. Ranibizumab monotherapy led to a significant greater reduction in neovascularization area with minus 3.8 square millimeters in comparison with the panretinal photocoagulation group with minus 0.9 square millimeters, and the combination group had minus 2.6 square millimeters. BCVA change from baseline to month 12 was statistically significant with ranibizumab with plus 1.1 letters compared to PRP with minus 3.7 letters. It's almost 5 letters difference, and in the combination group it was minus 1.1 letters. With ranibizumab, central subfield retinal thickness led to significantly lower retinal thickness from baseline to month 12 compared to PRP and to the combination group, with a plus 35 microns in the PRP, plus 17 in the combination, and minus 5 in the ranibizumab group. There were no new findings concerning ocular severe adverse events. It was 2 in each group. We had 1 hemorrhage in each group in the vitreous, and 2 patients in the PRP and 2 in the combination group received vitrectomy. There were also no new signals concerning APTC events. We had 1 myocardial infarction in each group. In conclusion, PRIDE is the first phase II study on proliferative diabetic retinopathy with ranibizumab in patients without diabetic macular edema to directly compare 3 treatment arms, ranibizumab monotherapy, PRP, and the combination. We did not find any new safety signals. This is a patient from the combination group. You can see at baseline neovascularizations elsewhere, and they have completely regressed after combination therapy at month 12. After 12 months treatment, ranibizumab monotherapy significantly reduced neovascularization area versus PRP, resulted in significantly better visual acuity outcomes versus PRP, and led to significant reduction in central subfield retinal thickness versus PRP and the combination group. Within the 12 months, we had no additive effect of ranibizumab plus PRP, and this is a patient from the monotherapy ranibizumab arm. You can see the neovascularizations at baseline, and at month 12, the neovascularizations have completely regressed. I want to thank the PRIDE study group, and I thank you for your attention.
Thank you. Extremely interesting study. And when you compare this to Protocol S, you gave a lot less ranibizumab, and I think the amount of laser was more. So I have several questions for you. Why do you think there was such a big difference in terms of the visual acuity? Do you think the more PRP may have caused more edema? Is that the explanation?
We know this from the old days diabetic retinopathy study that one complication was macular edema, also resulting in visual loss and clinically significant macular edema. So this is due to the panretinal, it's a side effect of the panretinal laser.
Was that the only reason? Were there other reasons for loss of vision as well, or was macular edema the only reason?
Actually, it was just macular thickening. We did not have to treat within the 12 months for macular edema, but there was no other reason. We did not find more ischemic maculopathy or vitreoretinal interface changes. There was nothing else.
Thank you very much. It's very interesting. So last but not least, now Paulo Stangar is going to present us